which among proven efficacious procedures is most appropriate for a situation. And I fully support that work, and I think that it should continue. It may be that in health reform, the greatest gain is implementing that we already know that is not controversial. So if you look at reports of new science getting through clinical trials and into practice covering a range of 17 years, or if you look at a large-scale evaluation of what percentage of the population receive evidence-based care and you come up with 54%, it may be that comparative effectiveness research should expand beyond clinical science and really start to get into the science of healthcare delivery. What do we do to practice more reliably and consistent that we know how to do that maybe doesn't carry some of this concern about emerging science, misapplication of data? So I'd like to see a continuum of comparative effectiveness research, starting with and continuing to emphasize clinical science, but phasing into how you implement that clinical science. And I think that was a part of the idea that Zarhuni brought to NIH, but has not yet really been implemented.
Right. Unfortunately, for all the talk about comparative effectiveness being the gold standard, there isn't one study that compares the impact of using CER approaches to traditional practice, not one. So, for all their talk about being evidence-based, not very evidence-based. It's, here's what we believe people should do versus what people are doing. And, if you want to spend another $100 million doing those kinds of studies, as opposed to spending, it's a mess.
So one comment on this, and that I think it goes back to the communications issue a little bit, and that is that when we do research, historically, our disposition of that research, the primary objective is publication, right? So that you get the research out in the public.
Well, I thought it was discovery.
Well, no, I mean, so once you do the research, it's getting it out there so that everyone sees it and understands it. But here's the challenge. I went to Medline. I went to the National Library of Medicine to get the stats on the number of new citations that hit Medline every year. Does anyone have any idea as to how many new citations are entered into Medline each year?
A lot.
I guess the question is, how many of those are data mining operations versus original research?
So the point not being that. The point being more around, if we think about publication as the ultimate way to communicate, then we're thinking wrong, because there are 700,000 new citations that hit Medline each year. And so the reality is, and they're entering in between 2,500 and 3,500 per day in that staff, and they're only covering 25 to 35% of the literature that's out there. The challenge being is that it goes back to when you brought up the point about being so long from bench to bedside on this, and any type of evidence we're generating, clinical trial, comparative effectiveness, any type of evidence, we've got to do a better job of getting into the hands of the decision maker, and publication is not the way to do it. You need to publish, and we do a lot of that. That's not the issue. But you've got to get what's been published into their hands, because when they've got 13 minutes, they don't have time to go out and read everything on that's new. They have no way, yet we hold those physicians accountable for that.
Yeah, publication has become sort of old school.
Yeah, and so you've got to take the patient that's sitting in front of you and make a decision on Mrs. Jones on what to do with her diabetes, and there may be 15 new studies out there that tell you, regardless of the type of design it is, that tells you what to do, but you have no way of getting them, and then understanding how does that apply to her specifically, right, and what to do. So I think that's our opportunity. That's the gold mine, is that piece of it, is figuring out how to do that.
Well, sadly, we're going to have to end on that note. I think we all would love to sit here and continue this panel for another hour or more, but what a terrific panel, very insightful. Thank you all very, very much for being here. Let's give our panelists a round of applause. Thank you. And Fran Marie is going to tell us what's coming next.
Well, actually, it's going to be lunch. So we have 20 minutes where we will be setting up the lunch in the back room. So come on back, get your lunch, back to your places, because we'd like to start on time with our keynote for the luncheon. That's Dan Evans. Thank you.